This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection Web-Based Education Series. Today's presentation is titled Photobiomodulation for the Dental Professional and will be delivered by Sarah Jane Snyder. There is a large body of published clinical evidence for the effects of photobiomodulation, previously known as low-level laser therapy, on musculoskeletal pain. There is growing evidence that PBM works well on a range of oral pathologies and is beneficial for orthodontic procedures and orofacial pain syndromes. PBM can also reduce the use of anesthesia for children and be used to reduce the local discomfort of injections. Sarah Jane is a dental oncology specialist, expanding the use of PBM in dental practices and oncology centers for the benefit of both patients and providers. Reviews published by The Lancet, the British Medical Journal, and the International Association for the Study of Pain show that PBM improves the speed and quality of tissue repair, reduces inflammation, and has an analgesic action. As an attendee at today's event, you will learn what PBM is and how practices benefit from its use, the specific mechanisms of action, and how PBM benefits your patients and your community. Attendance at today's event entitles you to apply to receive 1.5 hours of PACE-approved continuing education credit. Shortly following Sarah Jane's presentation, you will receive information on how to apply to receive your CE. To be eligible, you will need to successfully complete a brief quiz, as well as note the following course number, which is SNY 082522. Again, that's SNY 082522. And now it is my distinct pleasure to welcome to the Practice Perfection stage, Ms. Sarah Jane Snyder. Hello, Sarah Jane.
Hello, thank you, and hello everyone. I hope everyone's having a good evening. First off, thank you so much for joining me today to learn a little bit about how photobiomodulation can be used in dentistry. I'm also a dental hygienist myself, so I think that's important to keep in mind that being operationally in the clinic, I understand that what we see in our patients using PBM could be extremely beneficial for them. So that's one of the reasons why I give this course, is just so that you guys can get an idea of how you can really apply this in your practice on a daily basis. So I'm gonna go ahead and just start jumping in. The first thing that I wanna talk about with you is if you've heard PBM, which many practitioners have, great. If not, I want to stress that this is not a new technology. This is something that has been around for a very long time. It actually is dated all the way back to the 1916 with Einstein when he first proposed the phenomenon of stimulated emission light amplification, stimulated emission of radiation, so laser. Or it can go even back down to the 1960s with Ted Naiman. He was the first person to invent and build and patent the world's first laser. Or 1967 with Professor Mester. He actually found out that laser biostimulation was very effective. Specifically, he had 2 groups of mice. He shaved the hair off both of them. One got red biostimulation light, the other one did not. And what he thought was going to happen didn't actually happen. What ended up happening is that the mice that had the red laser shined on them, they actually ran around quicker, their hair grew back faster, and they were doing much better versus the control group. So like I said, it's been around for a very long time. As you can see, there's been 800 clinical research trials, over 4,000 laboratory studies, 680 papers published in 2020, which is about 56 papers a month, and 8,000 academic papers in total. Now, not all of these papers and publications are specifically to dentistry. They are, as mentioned in the intro, to all aspects of physical health, physical and mental health. So one of the things that's really key here is when we're talking about photobiomodulation and this technology, it's very important to realize that this technology, because it's been around for a very long time, it's gone by several different names. So there's a huge list of different names that this technology has gone by, 100 different names to be specific. In PubMed, we actually have a database where we will search all these different terms, plus an additional 200 terms just to pull all of the research that's been published. Some of the most common names, which you're probably already very familiar with, are things like low-level laser therapy or low-level light therapy, or LLLT to be short. But in 2016, it was accepted in the National Library of Medicine to be known as photobiomodulation therapy. And that's what they said. They said, this is what the name is for this technology. And the reason being is that it's extremely descriptive. Photo meaning light, bio meaning life or cells, modulation, the ability to change. So PBM is the acronym that we use for this technology. So going forward, you'll always hear me refer to this by its dubbed name from 2016, which is PBM therapy, or PBM. So as I mentioned, this is something that's been around for a really long time. And you may not already know this, but it was actually introduced to the general public in the 60s and 70s. And I have a quick video to show you what that introduction to the public actually looked like. Star Trek. So a show from the 60s and 70s, when somebody got injured in Star Trek, they were taken to the sick bay, they were shined a ruby red light on their injury, and they would heal instantly. Now, it doesn't work that fast, but it is essentially what we do. We have the ability to shine light on patients and they get better more quickly. Now, honestly, I've never seen Star Trek, but I have seen Star Wars. And there's a very big difference here because Star Wars red light is ablative. It is made to cut through tissue and bone. It's very important to remember that not all lasers are dangerous and not all lasers are the same. There are different classifications of lasers. Starting when we say the word laser, a lot of times we're thinking class 4 lasers. These are the ablative lasers that cut through bone and tissue. Ablative lasers are very common in dental practices. We use them every day for dental surgeries and things like that. But just to know that there is a difference. Thor, that's who I work for. We are strictly a photobiomodulation company, and we only do class 3B lasers. So the difference here is that they're non-ablative. So they are lower powered lasers between 5 to 500 milliwatts that are specifically used to stimulate healing and taking away pain, specifically for the application of photobiomodulation. So no cutting or ablating. But another really interesting point, especially in the realm of dentistry, is LEDs. LEDs are a class of their own. They're not in the laser classification, but we use a lot of LEDs, and I will talk to you about how we use them in a few slides' time. But first I want to touch upon class 3B versus class 4 lasers. And I think this is really important because, like I said, class 4 lasers are extremely common in the dental practice, but so are class 3Bs. And there are some differences that we have to consider when we're talking about the different classifications of laser. So one of the things is obviously power, which I've kind of already mentioned this, right? So class 3B lasers are lower power because they're not ablative. They don't need to cut through the tissue, they just need to stimulate the cells. So in that aspect, class 3B lasers are anywhere from 5 to 500 milliwatts, where class 4 lasers are from 500 milliwatts and above. Then we also have to look at size. When we're usually working with class 4 lasers, they tend to come in smaller sizes because they need focal points in where they're doing their cutting and their ablating, where class 3B lasers often can be a little bit bigger in size because we're not ablating. Again, we're covering larger tissue area so that we can do that stimulating PBM dose. The difference between coherent versus non-coherent, having the ability to use one wavelength of light or multiple wavelength of light. This is another really great thing when we're talking about LEDs, because with LEDs, we can use non-coherent, so multiple wavelengths to do different applications. Non-contact versus contact, focus versus defocus beam. These are all different things as well. Typically, you don't want to make contact with the class 4 laser on the tissue because of the fact that it is ablative, where class 3B, typically you can make contact with the tissue, ensuring that you're getting that dose into the tissue. Now, I do know that there are certain class 4 laser companies out there that they have almost like a spacer where the active beam is, I like to use my pen as a demonstration. Unfortunately, you cannot see me right now. But imagine a pen that has a pen cap, right? Your active laser tip, it goes inside a spacer and then you put that spacer onto the tissue. So you still are making contact, but you have to realize that the amount of energy that's coming from that activated tip needs to work harder and go through that plastic piece before it actually gets to the cells. So something to consider as well. It loses energy the further that it travels. Diffuse versus collimated. Again, having a collimated beam is like using a laser pointer and pointing it at the wall, right? The closer you go, the further you go, all that energy is focused in that one point, versus diffuse beams, the energy is like a flashlight. So if you do a flashlight at the wall and you get really close and then you pull it away, the working area gets bigger. And there is a difference when we work with class 3B lasers. A lot of them are diffuse beams, and class 4, again, collimated, because they have to be very precise in what they're doing when you're doing things like surgery, cutting and ablating. Risk and regulation. This is the biggest thing that I see when it comes to dentistry, is risk and regulation, because in the United States, it depends on what state and regulation as to who can actually be able to apply these technologies to patients. If you're more from the West, like California, or even, Illinois, Colorado, dental hygienists can use class 4 lasers. Some states say that you have to use them for specific applications as a dental hygienist, so specifically for bleaching or for LBR, laser bacterial reduction. Other states, like if you come more towards the east, you're not allowed to use class 4 lasers at all. If you go south to Texas or Florida, you're not allowed to use lasers, even laser pointers, at all in those states. So, risk and regulation, there is a little bit of a difference. Also, when we think about risk, the only risk you have with the class 3B laser is potential risk of eye injury when using the actual laser application. Now, this does not account to LEDs, but the risk with class 4 lasers, it's higher, which is why it has higher regulation in the dental practice. So just some things to think about. And now, of course, like I said, I do work for Thor, and we are a class 3B laser company that also uses LEDs. I see the benefit in the dental practice of having both lasers. Majority of the dentists that I work with have both classes of lasers because they're both very valuable to do different applications, but they also work really well together. So something to think about. Having both is extremely beneficial for you. So we're gonna get into photobiomodulation and how it works exactly. What I want you to think about is it's a photochemical effect. Again, it is not a heat therapy, it's not ablative. It's a photochemical effect, which these are very common. They happen all around us every day. It's very much like photosynthesis, where plants use light to synthesize, grow, and function properly like they're supposed to. Or we use light when we lay out in the sun and our skin changes color. That's a photochemical effect. Where we use sun to synthesize vitamin D, that's a photochemical effect. It's also a photochemical effect, which is probably happening at all the hospitals around you, which is for neonatal jaundice. That's using blue light for a photochemical effect. It's also extremely common now in dermatological conditions such as treating psoriasis and vitiligo, the photochemical effect using different wavelengths as well. So I'm going to look a little bit closer at the actual mechanism of action of what's happening within the cell process when we're doing this photochemical effect. So the leading mechanism of action of how PBM is working on our patients is that you have a normal happy cell. Inside that cell, we have the mitochondria. Inside there, we have cytochrome C oxidase. And what we're seeing here on the screen is this is the electron transport chain. When the oxygen goes in, it binds with cytochrome C oxidase, and this is how we create cellular energy, or ATP. However, when the cell is sick, stressed, or just old, nitric oxide will bind with cytochrome C oxidase. This displaces the oxygen molecule and reduces the production of ATP. Sadly, what happens is when we have that constipation in the electron transport chain, we start to create ROS, or reactive oxygen species, also known as free radicals. The really critical thing about ROS is that it's the leading process to inflammation in the body and eventually cell death. However, having the ability to shine light on the cells at a certain dose, at a certain wavelength, we can displace that nitric oxide, allowing oxygen to rebind with cytochrome C oxidase and start creating ATP again, cellular energy. And what this does is it allows the cell to function properly again to do the jobs it was meant to do. So very important. So what does it do for our patients? Well, we can improve the speed and quality of tissue repair, we can reduce inflammation and edema, we can improve blood supply, and when we're using our lasers specifically, we can induce analgesia or a local anesthesia effect. And this has everything to do with the dose response. There's something called the bell curve, which means how much light we put into those cells and how those cells react. So if we put a little bit of light in those cells, we actually will get little to no effect. If we put a bit more light into the cells, this is the optimal effect for stimulation when we want to stimulate those healing and repair type of applications. If we put a bit more light in, we can actually start to lose the effect. And this is what happens when you use really high wavelengths. It actually gets absorbed into water, so it's not as effective to use higher powers when trying to do a PBM effect. If you do even more light, this is when we start to get that inhibition effect with the sensory nerves, and this is where we create that induced analgesic or local anesthesia effect when using PBM. But ideally, if you want to do anything in regards to improving speed and quality of tissue repair, reducing inflammation, and improving blood supply, it's that therapeutic window of stimulation that we really want, where we can reduce that ROS and increase that ATP to stimulate healing for our patients. So going forward, just trying to recap a little bit for you. Again, when we do PBM, we're doing two things really, really well. And those two things are either stimulate for healing or taking away pain. And you can see that when we're dealing with something like inflammation and pain, you can see how this can be applied to pretty much every single patient application. If you haven't seen our equipment, again, I work for Thor. This is what it looks like. I'm just gonna kind of go through so you can get an idea of the different things that we use and how they are applied. So this big guy here, this is actually an LED. I did say we use a lot of LEDs. The great thing about LEDs is that they're not lasers, so you don't have that risk with the eye injury. Plus LEDs, anybody in any state can use them. So it's really great to be able to have your assistant to use it, or quite frankly, the patient can use it on themselves. But the LED is really optimal for trying to stimulate healing. You would use this extraorally because it is quite large. Think about like a softball. That is the size of this, so it covers the entire cheek surface. This here, this is a laser. It's a class 3B laser, and this is for deeper penetration. It's really good for relieving pain, specifically in the TMJ joint, or if somebody has, TMJ or trismus, that's how you would use this product here. Then we have the same thing intraoral as we do extraoral, one that is specific for healing, which is where you see my arrow now. This is an intraoral dental probe for specifically healing. And then we have one for specifically taking away pain as well. This last probe here is actually one of my favorites. It definitely makes us unique to the market. This is what we call our trigger point probe. If you don't know what trigger points are, they are tender points that are hyper irritable, also known as myofascial trigger points. They're, irritable spots that usually are taut bands of, skeletal muscle, and which are painful upon compression and usually give rise to referred pain. So the thing about trigger points is currently in the dental practice, how we get rid of them is by palpating, doing dry needling or Botox. With this, we have the ability to not only deactivate those trigger points for you using lasers, which is extremely comfortable, the patient doesn't even feel it. We also have the ability of finding those trigger points, because one of the things that I just mentioned is that it is usually causes referred pain. So a patient can say that they're having pain, near their chin, but quite frankly, it's coming up from around their ear. You have the ability of finding that referred pain and being able to, deactivate that trigger point at the site of where it's actually coming from. So the next probe that I'm going to talk about, and the reason why it gets its own little spot, is because it is a newer probe. It's only been out for about 2 years. This is what we call our Lollipop probe. It is an intraoral probe. It gives full 360 PBM to the entire oral cavity within 1 minute. So this is LEDs. This is not lasers that we're using, but as you can see, it would be extremely beneficial to, after every single, SCRP or dental surgery, to give that healing PBM to that patient just by having them pop it in their mouth for 1 minute, full 360 PBM, and you could be writing up your notes as they do that to themselves. So love the Lollipop probe, one of my favorites. The next 2 things that I'm going to talk about, just to kind of give you an idea, because we are going to talk about protocols and how we apply it within the dental practice, is that there's 2 things on our base unit, such as time and frequency. So I've talked about 2 things. I'm going to say them again. We talk about healing, which on our base unit, anytime you do something for healing and repair, it's 1 minute, 2.5 hertz. If you do anything to take away pain, you're always going to use continuous 30 seconds. I know we have a lot of settings on here, but those are the only 2 ones you're going to use. Reason being for the other settings is because we have a bunch of other different probes and interesting things that we use the other settings for. So practical application. How exactly are we going to use this in the dental practice, especially on a daily basis? So we have digital PDF or printable protocols. They're 1-sheet protocols that basically talk you through step by step each treatment condition on how you would use it. One of my colleagues said it's almost like a cookbook. That's how he refers to it. He loves to talk about it in that sense. But it's a 1-sheet, tells you all the information that you need to know, and there's always pictures corresponding with probe placement, so you can get an idea of how exactly you would use this for your patient. I'm just going to talk you through step by step. This one specifically is on dentine hypersensitivity. So again, it's something that we would see for a lot of patients. Always look at the keywords. Because of probe placement, sometimes we can use the same protocol for different applications, so you'll see different keywords in here. This is pretty much the same: dentine hypersensitivity, whitening-induced hypersensitivity, root sensitivity. This is all the same protocol. It always gives you a treatment plan, how often we need to be doing it to get that good effect that we're looking for, our intention, why are we using each probe, what are we planning to do with it, which probe are we going to use, is it going to be intraoral probe, an extraoral probe, and which one. This is where we find out how we set our base. Our pulse, is it going to be continuous or 2.5 hertz? What are we trying to do here? Take away pain or stimulate healing? The time in which we send, and then the treatment targets. So it's going to verbally explain to you exactly what you need to do, where you need to place that probe to get that positive effect. So going from left to right, like you would be reading a book, the first thing we do is pick up that intraoral probe because we want to deactivate the local tooth sensitivity. We're taking away pain here. So we want to set continuous 30 seconds, and then we follow specifically like it says, treating the specific tooth that is having that chronic sensitivity intraorally on either side of the affected tooth, 5 millimeters below the gum line. To give you an example, this is what it would look like, where you're placing that probe directly on the tooth, 5 millimeters below the gum line. And again, we're placing that light directly to the tissue. We don't have to hold it away. We don't have to, swing it back and forth. Because this is a class 3B laser, we can apply it directly to the tissue to ensure we're getting that maximum positive potential into those cells, because we want to stimulate that really good effect. Next thing is to do extraoral application. So this is for analgesia. So it's to take away pain. So same thing, continuous 30 seconds. The one thing that I'd like to show here is that it's an optional step. So typically you can get away with just doing that intraoral application, but if that patient is still saying that they have additional pain, you basically just use this extraoral probe along the nerve that's associated with that tooth, and this will help ensure that that pain level is taken away for them. So just to give you an idea, and this is what it looks like when we're doing on a patient, you do it over the appropriate tooth along the nerve that is having that sensitivity. And all of the protocols are backed by research. So research like this one. This was research done on dentine hypersensitivity at the University of Barcelona. It was done on 30 patients. And what they found is by doing one treatment of PBM, one treatment session on 30 patients, and they followed them for a course of 2 months, they showed there was a significant reduction in both tactile and heat sensitivity. So if you're looking at the graph, you can see the blue bar is the bar that has the PBM, and the green bar is the bar that is the control. So a significant reduction followed by 2 months in both tactile and heat sensitivity. Now, this is a great demonstration that we like to do at conferences, and we actually did it on an engineer at one of the dental conferences we were at. We did not have the internal sleeves to put the intraoral probes in, so we just used the extraoral probes on this gentleman. However, pay attention to his amazement when he realizes how quickly it worked for him. All right.
What is your name and profession?
I'm Jim Freeze, and I'm an engineer.
You're an engineer. And tell us, what were you suffering from?
I had a sensitive tooth.
And what happened with laser? What did Mark here do for you?
So Mark got me some ice water, and I tried to switch it around, and it was really painful. And then we did a laser treatment for 45 seconds with that.
Okay.
We did that through the cheek on the outside because we couldn't use the internal tools.
Yeah.
And now I'm drinking cold ice water and switching it around, and there's no sensitivity.
And how long did it take for that effect to take effect?
It was immediate, but it's been about a couple minutes since then. It's actually getting better. It's actually getting less sensitive as time goes on.
Thank you very much.
Wow, take a moment for that to sink in. His sensitivity is just getting better as time goes on. What do you have in your dental arsenal of products that can do that? And that's the really cool thing about PBM, is that because PBM is flipping the switch on those cells in a positive aspect, not only does it take away the pain pretty immediately, there is a waterfall effect that will happen where even though we are aiming at those top cells, the cells underneath, that waterfall will happen and it will just continue to get better. So that is the really awesome thing about PBM, is that it constantly helps patients heal. So the next common application that we're going to talk about is extractions and how we can use that for, again, a healing application for extractions, another protocol here. So first step is we want to stimulate the lymph nodes, and the reason we want to stimulate lymph nodes is because lymph nodes are associated with reducing inflammation and edema. So we would use LEDs, 2.5 hertz, 1 minute, and we would go over the cervical lymph node chain on either side of the extraction site. So you can see that here. This is what it looks like on a patient. Now these are LEDs. The patient is wearing safety glasses for the LEDs, and that's okay just because it's really bright. It's always good to have your patients get into the active use of always wearing safety glasses. So that's that, but you can see it's so large, it's covering the entire neck surface. So a lot of surface area covered there. The next one is we want to heal the area where we had taken out the tooth. So we want to use a 660 nanometer And we're going to do 2.5 hertz for 1 minute because again, we want to heal, and we want to heal where that tooth was extracted. So we're going to put that area, we're going to put that probe over the extraction site. If it's a posterior tooth and a very large tooth, you might want to do 2 sites. If it's an anterior tooth or a deciduous tooth, something a little bit smaller, you could do just 1 site. And then this is another optional step. If it was a difficult extraction, you really had to kind of get in there, you could also do an analgesic step, which continuous 30 seconds optionally, and you would do it similar to how we did dentine hypersensitivity. You would do it 5 millimeters below the gum line on the tooth in which that was extracted, and that would help just alleviate some of that pain for them. Again, if hypothetically this tooth was extracted, that is where you would be placing that probe. Dental anesthesia. So this is an exciting one. I know it was mentioned in the intro as well, but dental anesthesia is one of the most common uses for PBM in the dental practice, where you can use laser for dental anesthesia. So I'm going to show you a quick video of what it looks like to get a tooth extracted and an implant placed with nothing but Thor PBM for dental anesthesia. You're probably saying to yourself, Sarah, that's a normal extraction. That's my point. It's a normal extraction. I know we talked about how PBM can help stimulate circulation, but when it comes to doing extractions, you're not increasing the bleeding rate when using this for local anesthesia. It's a normal extraction. They're not thriving in pain. It's the same thing. And here's the protocol that we used. Oh, fun fact on that last one there. I hope it doesn't play again, it may. Fun fact on this here is that this is actually Thor's CEO and founder, James Carroll. He decided the best way to figure out that this protocol would work is to try it on himself. So he's living proof that by using PBM, you can take out your tooth and put in an implant with no need for a needle. And this is the protocol that he used. He used the, taking away pain here. So we're taking away pain, the 810 intraoral probe. He did it along the nerve of his posterior tooth. Now he did set the time higher because he wanted to ensure that he had that anesthesia effect. And it lasted for 20 minutes. The great thing is after he did the full protocol of anesthetizing that tooth with laser, after that 20 minutes, he started to feel it a little bit again. Instead of having to do the full protocol again, he just did 1 minute on the buccal, the lingual, and he was good for another 20 minutes. So he continued to do this for his entire procedure, and he did not need any needles. Why this is so great is because it's really great for those patients who are extremely needle phobic, children, it's excellent for previous drug and alcohol abusers who refuse getting anesthesia, or just that holistic approach for painless treatment. I have been asked if you can shorten this treatment, and the answer is yes. If you have a pediatric deciduous tooth, you can definitely do less time for these patients and still, get that full anesthetic effect. I personally have seen this done on a dentist who we were removing large amalgams and we were putting in composites. We only did 30 seconds per point for this patient and totally were very close to the nerve, and they were sufficiently numb. They didn't feel anything the entire time. So great opportunity for using it on those specific people. Oral lesions. So I said the 2 main things we do for PBM is either healing or taking away pain. So PBM is significant when treating oral lesions, things like aphthous ulcers, traumatic ulcers, herpes simplex virus, pizza burn, those normal cuts and scrapes we get from eating all types of yummy food. We can stimulate to accelerate healing and reduce pain for these common oral lesions, which is very helpful for our patients. Again, it's always backed by research. This one is specifically looking at stomatitis in 60 pediatric patients. This is reoccurring chronic stomatitis. And what they found is that by using PBM, they did 3 treatments in 7 days. They were able to reduce the size of the ulcers and also the pain that was associated, and this was statistically significant. So it's considered an effective treatment for managing recurrent aphthous stomatitis in children. So this is really great because when you have a fussy child, that is no fun at all. This is actually a newer study that was just published out of Italy in 2020. So very beneficial that we have the ability to drop that sore size and reduction of pain by day 4 versus waiting all the way until day 10. Trismus. This is another one that I have personally witnessed and have done. So trismus, it can be very effective for trismus patients, specifically patients after getting third molar wisdom teeth extractions. That is what happened to the patient that I worked on. They had lockjaw 6 months after getting third molar extractions. They could barely open their mouth to bite into a sandwich. I think we measured her about 9 millimeters of his incisal opening. We did 1 treatment of PBM, and she went from 9 millimeters to 15 millimeters with 1 treatment. So that was a 6 millimeter difference with 1 treatment. She was so happy that she could go home and she was able to eat a little bit better and obviously open her mouth a little bit wider as well. Again, there's research backing this as well. So this is specifically looking at 32 patients. It is a comparative study looking at using acetaminophen versus a laser treatment. And what they found is by doing this on patients who had their third molars extracted, they were able to have a faster recovery, increased incisal opening, and also less pain, which is fantastic from day 2 compared to day 7. TMJ, this is another one that is extremely common in dental practices, specifically if you work with adults. I know during the pandemic, a lot of people that I've worked with were saying, you know, TMJ was all over their office because everybody was very stressed. So TMJ is one of the main applications you will definitely see, and PBM is extremely effective for. This one was looking at patients looking at pain scores and TMJ. So they did look at incisal opening as well. They did 1 treatment and then followed them for 2 weeks and found that after 2 weeks, there was a statistically significant reduction in pain scores and better opening for these patients. Now, this was done at Tufts University by actual Dr. Mark Dincher himself. We have a little video of him explaining how he uses PBM in his practice. I do like to show that, so we're going to go ahead and show that next. But I do apologize, it is a bit noisy because we were again at a conference, so you're going to hear a little bit of noise, but it's a really good video. So let's play that.
I'm Dr. Mark Dincher. I'm a dentist in Central. I belong to a large 4-man group, craniofacial pain, typical pain problems, full mouth reconstruction, and sleep dentistry and the like. I came upon aspects of low-level laser therapy. I now use them far more than I use the surgical lasers. In fact, I use them on every single one of my patients. They have 3 really great qualities. One is that they have anti-inflammatory. The others are analgesic and stimulative when you're doing small surgeries every day. That's the guts. One of my patients who just had a rather severe surgery. She had a sinus lift, and she's a diabetic patient, and I hadn't seen her right after the surgery. When she got back to me, she was miserable. I'd been that way for weeks. I hadn't known about it. So I would use the lasers with her and to take care of her for her and reduce the pain. And I got a call back that night. She was absolutely livid with me and wanting to know what the hell I was not having that for her the very minute she had the surgery. She the next day called my surgeon, wanted to know why he wasn't using the low-level laser therapies. And he called me and says, what the hell's a low-level laser therapy? Because Barb called me and reamed me out about that. I'm actually doing some research at Tufts right now. The research is the use of low-level laser therapy as initial therapy and chronic TMD patients. I'd say the most common thing is their analgesic quality in dentistry. That's something that you'll pick up at every patient because you're doing small surgeries and you want to be able to decrease post-op pain in any sequence. Secondly would be either the anti-inflammatory or the stimulator. Reduce the anesthetic for my children working on baby teeth by 80% with a low level. Now I reduce from having to use anesthesia.
So like 80% of the patients who might require it don't have it anymore.
Exactly. And about 30% reduction in using anesthesia in my adult patients. I now actually use it to differentiate between reversible and irreversible pulpitis and am able to most toothaches now treat the toothaches without analgesics just by using the laser therapy. Then I measure how long they stay pain-free, and oftentimes those cases where we would normally be scheduling them to have a root canal done, we are able to manage them in other ways. So that portion of it is quite remarkable. The stimulative aspect of it works equally as remarkable. And such things as orthodontics, where you can actually be able to stimulate teeth to erupt if you have delay in timing with them. Stimulate repair and peripheral nerve damage. Those are areas that truly, really rescue the patient.
All right, so like I said, when we are working in the dental practice, we can use PBM for stimulating healing of a lot of different things, or we can use it for taking away pain. And you can apply that to a lot of the normal things you see in every single day practice. However, we like to have the ability to also treat really difficult things as well. Things where there really isn't another adjunct in clinical practice to use. So I'm going to go through some slides of really difficult type of things where PBM has been effective for them. Not all slides will work for each dental practice. It's more rather for specialties. But if you have any questions on how you can apply certain PBM applications into your practice or for certain conditions, please feel free and contact me. I'm happy to have this discussion with you. But the first thing that we're going to talk about is osteointegration. So osteointegration is something where there has been benefits showing that PBM helps stabilize the implants. Looking at the bone volume as well. So by using PBM, we can actually increase bone volume around the threads of the implant itself to increase stability of that implant. So something that can be very impactful if you are treating patients and placing implants. Things like cystic defects, bone regeneration. Again, we're trying to stimulate bone growth. It might be a little bit hard to see in these photos, but the laser group is all the way on my left, maybe you're right, my left side, and the control is on the right. And what they did is they removed the cyst, they applied PBM immediately after the cyst removal, and they treated these patients 3 times a week, twice a week, so 7 treatments in total. And if you look at the bottom picture, you can see that the laser group, actually you can see there's more bone development there. They followed these patients for 90 days. In addition, they also saw that there was a significant decrease in pain. So the first primary significant increase was bone level. The second one here was actually a significant decrease in pain as well, as you can see from this chart. By day 3, patients had a significant decrease in pain versus the control, which really had to wait until that 9-10 day mark, similar to that stomatitis study that we saw as well. So we have the ability to increase healing, and when we do that, inflammation is often associated with that. reduce the inflammation, the leading cause of pain, means that we then do reduce pain. So PBM. Gingival papilla regeneration. Now, this was a very small case study, so there's not too much research on this, but it has been shown to be beneficial. For this specifically, these were patients who were getting new veneers. So what they did is they put veneers on these teeth, they used a perio probe, and they slightly stimulated bleeding, the aim to release mesenchymal stem cells along with the blood to favor that neurovascularization and reconstruction of the interdental papilla. After 6 treatments, these are the areas in which they treated. After 6 treatments, they found that the papilla started filling that embrasure space for these patients. So they did this for 3 weeks, and they were able to get that space to fill. This is really important, especially when we're looking at cosmetic dentistry, to have the ability, because nobody wants brand new, beautiful veneers and then have dark spaces in between. So this is another application in which you can try. Neurosensory recovery. So these were patients that had extractions of their wisdom teeth 12 to 21 months after, and they had paresthesia. So again, a really difficult thing, having paresthesia for 12 to 21 months after extractions. These patients got 20 treatments for 7 weeks, and what they found is that they were actually starting to get neurosensory recovery. So their nerves were coming back after 39 days. Facial paralysis. So this patient specifically was dealing with some Bell's palsy. They got 6 weekly treatments, and you can see the before and afters here in where the patient is able to smile better, she's able to close her eyes better, pout better, and raise her eyebrows. And again, this is all about just stimulating those cells so they can function properly again and helping to create those positive neural pathways so everything is just working properly again, just by using that PBM to flip that switch. Another difficult thing that we see in the dental practice pretty frequently is things like burning mouth syndrome. So this is another statistically significant study where they did 2 treatments per week for 5 weeks, 10 treatments in total. The PBM group is the group with the least pain scores, so the orange versus the blue, that's the control. And by using PBM 2 times a week, for 5 weeks, 10 total treatments, we were able to reduce that burning mouth syndrome for them. And it followed all the way from 1 month to 4 months and found that it stayed reduced for these patients. So pretty great. Post-herpetic neuralgia. So neuralgias in general are very difficult to treat in the dental practice, and there's not much that we can do for these patients except for PBM. So PBM, we use PBM for these patients, and it was a crossover trial, so you can see that the colors will switch. So it started off that the PBM group, which is the orange, versus the control, which is the blue, those PBM patients, they had significant less pain, and then by week 4, it flipped. So patients who weren't getting PBM now are, and you can see that decrease, that orange line, in which those following weeks, they started reducing their pain and getting their sensory back as well. But the interesting thing is the patients who started getting PBM in the beginning continued to have that positive effect for that full 8 weeks out. So that's really great for them. And as you can see, there's just some additional information here about the follow-up months, such as 16 patients, which is 80%, maintain the reduction in pain. 2 of the patients returned to pain scores of 4, but not requiring medication. And 2 of the patients returned pain scores of 6 to 8. So there was a lot of really good stuff here where we were able to reduce those pain scores for those patients. This is not going to be seen too much in all dental offices, but bisphosphonated related osteonecrosis of the jaw, something that is definitely dealt with, especially in regards to cancer therapy as well. So this is a study, and the reason why I like showing this is it's showing that its PBM is complementary. So This is, again, it's a comparative study and looking at doing different things such as antibiotics, PBM, surgery, and PBM together or by themselves. And what they found here is that by doing surgery, but also adding PBM is really, really good together and had the best results. It was statistically significant to have better healing and reduction of pain by using it together rather than surgery by itself or PBM by itself. Oral mucositis. So oral mucositis is similar to stomatitis, except for it is due to cancer therapy, and patients will get these painful oral sores all throughout their oral cavity, down their esophagus, down all the way through their digestive tract to their anus. It's extremely debilitating for patients who are going through cancer therapy. They can have it at the time of cancer therapy, but they can also have it as a long-term side effect as well. They could have it for years afterwards. And depending on their dose, they will get this as well. As you heard from the very beginning, my title is dental and oncology specialist. So I work with a lot of oncology departments within the US and Canada. We're well over 30 at this point. But this is something that there is nothing else out there. What they do right now to treat things like oral mucositis are things like magic mouthwash or what they call quote unquote cryotherapy, which is really just ice chips. And it really is not helpful for healing anything. It's just temporary relief of pain. So we can do PBM. And this is a little bit of an older study on PBM using for oral mucositis. We've had a lot more publications since this one. But using PBM on the WHO scale, which is grading from 0 to 5, we can see that the PBM group is the dark bars and the gray bars are the control. And by using PBM, patients had a less high score of oral mucositis. They also saw less pain as well versus the control. To give you an idea of the patients that are dealing with this, I actually have a patient case here. This is a patient who, due to the pandemic and the hospital supplies of PPE, they had to pause their PBM program for their cancer patients, unfortunately. But this patient was getting the radiation straight through her lips. So you can see how painful that is probably for her. She was in severe pain, unable to eat, drinking water was difficult, and she said even breathing was really difficult for her as well. So they said, nope, we got to do this for her. And they gave her PBM. Within 2 days, the pain subsided. Within 5 days, her lips started healing and crusting over. Within 2 weeks, she is dressed up and ready to go out to lunch. Now, at that 2-week picture, she's still going through cancer therapy. She just doesn't have to deal with the side effects. And that's how good PBM is at healing oral sores for patients and helping them, heal and get better more quickly and not have to deal with the pain of cancer therapy. We also use it on children. This is the Lollipop Probe being used at St. Jude's, and this is a little kid who's obviously going through cancer therapy at St. Jude's using the Lollipop for full intraoral treatment. Again, it's LEDs, so it's super safe for patients and super safe for practitioners, and it creates a really, really big impact for their patients. Another thing that we will look at is HypoSalivation. So HypoSalivation is something you're, again, going to see in a lot of patients, and it's something really difficult. We don't have much for that, except for, mouth rinses and things to try to help temporarily increase their salivary flow. But specifically for patients that go through cancer, when their salivary glands are irradiated, they can have long-term effects of hyposalivation where they forever have to use water or yogurt to try to consume their food. Well, we have the ability of also using PBM to help stimulate those salivary glands for these patients. And there were statistically significant results in this study. Specifically, they did it for 12 weeks, twice a week, and they found that we were able to increase the pH level, which as dentists, you know the importance of the pH level. We were able to increase that from 5.9 as an average to a 6.6, so much closer to that neutral pH of 7 salivary flow. So normal unstimulated salivary flow is about 0.3 to 0.4. We were able to get it to 0.35. So right there in between, which is great and statistically significant for unstimulated salivary flow and also quality of life. Patients do not like waking up in the middle of the night because their tongue is sticking to the roof of their mouth or their cheeks and having to swallow. Having the ability to produce their own saliva by just using a little bit of PBM on a salivary glands makes them much happier patients. So a lot of high reports of quality of life was significant for these patients. Laser versus NSAIDs. So what do NSAIDs do? When we take something like an NSAID or a Tylenol, we're basically just masking that pain and we're not healing anything. Obviously, when we use PBM, what we're mainly doing is we're taking away pain and we are healing something. We're stimulating healing. So there's definitely been research showing that by using PBM for patients, this was done on 90 patients, it's actually more effective, because we're healing something and taking away pain versus just masking and taking away pain. This is the same thing when we're working with opioids. So obviously there's still an epidemic with using opioids. You know, they say extractions and getting opioids at the time of those extractions at teenager age is a contributing factor to the opioid crisis. We have done research working with actual chronic opioid abusers, and we found that by using PBM versus using opioids, we can reduce the use of opioids by 80% in those patients. So because again, we're healing something, we're not just masking the pain. There was a recent data that was just collected at West Virginia University, again on pediatric patients. So if you don't know too much about the pediatric cancer population, a lot of them, when they're very, very fussy, they have to go on PCAs or, you know, narcotics, opioids to try to help with the pain of oral mucositis. And what they found is by using PBM on these patients, they went from an average of 80% of patients needing narcotics, children patients, to 0. So again, because we're actually healing something, we don't need masking of pain medications, which is great. So treatment expectations. You know, if we use PBM, what are we expecting to see in our patients? It's not magic, it is science, and it does take a little bit to get an effect. If we're doing something for an analgesic or a trigger point, those myofascial trigger points we talked about, that is pretty quick for that patient. We'll see that effect within a minute. But if we're working with that inflammation and edema, trying to do that healing effect, they're gonna start feeling a positive effect pretty immediately, but we have to wait for that waterfall effect and those other cells to react to get that positive effect. So that's gonna be about an hour, and full on repair is gonna take about a day. Number of treatments depends on what we're treating. If it's an extraction, you could get away with doing just one treatment and having a really positive effect for your patient. If it's something like chronic, something that they've had for a really long time, or something that, say, due to their bite, they're constantly creating this issue, you might need a number of treatments until they have that really positive effect as well, until you get that restorative, reparative effect. Again, how often? It depends if it's acute or chronic. At what point are you getting to it? Obviously, preventatively is always better for certain things, but in dental practice, you know, if you extract a tooth, that's an acute injury versus a chronic injury, again, is like a TMJ, something that due to their bite they've had for a very long time. You might need to do it on a consistent basis to get that really good effect. Vascular tissues respond faster, again, because what PBM does is we stimulate that blood flow, we kind of get everything in there. So vascular tissues will respond better. Non-vascular tissues such as cartilage and ligaments, or even like that neurosensory recovery, that's something that you need to do more treatments to get a better effect. The neurosensory recovery went for almost 40 days until they had a really positive effect. So keep on doing it for those really, really hard things. PBM is not antimicrobial. We're not killing anything. We are either stimulating for healing or taking away pain. But the great thing about stimulation, because we're making those cells work effectively again, we can also help the immune system kind of fight any type of infection that's in there. So that's the positive thing about PBM when we're thinking, you know, fighting, even though it's not killing anything. So there are tons of applications out there for dentistry, lots and lots of stuff on PubMed. Like I said, we have a database where we search 100 different terms in addition to 200 other terms on a bunch of different effects. So again, if you have any questions in how you could use PBM for your practice, please feel free and contact me, and we can talk about how you can start using it every single day. So PBM, ooh, where'd that go? There we go. Sorry about that. So one of my final slides here is PBM in a summary. The great thing about PBM is there are no known side effects, and I'm going to say that again. There are no known side effects of using PBM, and the significance of this is that it's great to be used as an adjunct to whatever you're already doing. There's no known side effects, meaning we don't have to worry about interactions with the modalities that we're already using. It's really great to use this in addition to, and we've
Excuse
done
me,
well.
Sarah Jane.
Yes?
Sorry to interrupt. We are recording this, but we just had a request if you could show the slides concerning mucositis once again. One attendee is particularly interested.
Which
Can
slide?
you show the 3 slides of the mucositis patient again? Amazing.
Yeah. Let me go back
Thank
there.
you.
Oh.
I guess it was a while back. And it is being recorded, but I just thought we would.
Yeah, no,
very
not a problem.
attentive. Okay, great.
So typically, I will say here that when we're treating oral mucositis in the cancer hospitals, we're typically treating oral mucositis preventatively. So we want to treat with PBM prior to that oral mucositis occurring. That unfortunately did not happen for this patient because of PPE supplies in the hospital practice. So this is, like I said, a patient who the radiation was going straight through her lips. You can see very painful. And then this is the next slide where they gave her PBM. So 2 days, the pain subsided. 5 days, the pain actually was gone and her lips were healing. And this is her at 2 weeks. So just to give you an idea of how quickly that had helped, relieve her pain and also help heal it as well. So I hope that
is remarkable.
Was good for you. I have more photos and patient testimonials like this. She's not the only one. Like I said, I work with well over 30 cancer hospitals, and we're on track for adding an additional 30 by the end of the year. So it should be mainstay treatment soon for all cancer patients. That's what we're working on when it comes to PBM and oral mucositis. All right, I'm going to go back to where I was, if that's okay.
Sure thing.
All right, so like I said, PBM, no known side effects, 30 million Thor treatments is what we've done. So it's really good as doing it as, with any other therapy you have. It never hurts to try PBM because there's no side effects, right? It's non-invasive. It's not an ablative therapy. You can use this on anybody. Children, the youngest child that I know who's had PBM treatment is 2 months. And again, that was also a cancer patient. It wasn't a dental patient. It was a cancer patient. So non-invasive, able to use on any single patient. It's non-toxic, which is great. We don't have to worry about overdosing patients on PBM. However, we have to remember there is that bell curve. We don't want to over apply PBM because it will be less effective. So that's the only reason, but we don't have to worry about a toxic effect. There are other wavelengths that are out on the market, such as blue light and green light, that actually do have a toxic effect to the patient and the body. So you got to be careful with those. But when we're working in the area of red and near infrared, it's non-toxic. So that's really beneficial. It's non-addictive. So while patients really love it, you would think it's addictive. It's not addictive. It's not, again, like opioids or anything like that, where people are going to have that addictive reaction to it. But I will say, one of the hospitals we work with all of the big hospitals in the UK, the NHS, I'm sure you heard of them. They are actually doing some studies right now looking at the psychological effect of using PBM, because their patients get so excited for their cancer therapy just because they know they get PBM and PBM makes them feel so good. I have a hospital out in Pittsburgh actually who had a similar results with their patients who received PBM, that they actually created a whole PBM clinic not associated with the hospital to refer patients, like, okay, you're done with your cancer therapy, but now go to this clinic and you can continue to get your PBM therapy, because they loved it so much and made them feel so good. And longer lasting pain relief than drugs. So again, this goes back to those opioid studies, the NSAID studies, the Tylenol studies. We're actually healing something for these patients. We're not just masking it with drugs. So it has longer lasting pain relief for these patients. It actually has that healing effect. So this is how PBM works. Again, it is not magic, it is science. We're just flipping those switch within the cells, so that way we can do those positive effects of healing and stimulating or taking away pain. And that's why it can be used for so many different things when we think about it on that biological level. One more thing before I go, because this is becoming one of the biggest things in dentistry. I can't tell you how many dentists are starting to put what we call the Novathor, which is a full body PBM bed, into their practice. Why are they doing that? Because we get so excited. Dentists know the powers of PBM and how positive it can be for their patients. If it works in the mouth, they're like, why can't I treat arthritis? Why can't I treat this person's knee? And because we know that within the US, our licenses only allow us to treat within the head and neck, the Novathor is actually considered a wellness device. Anybody can purchase one, anybody can use one, FDA class 1. So dentists are putting this in their practice so they can treat all their patients' other ailments. And it also has the benefit, the fact that we already know we have an oral systemic effect. So if there's something going on in the oral cavity, there's some pain inflammation going on in the body, this takes care of it all. So for healing those anxious, nervous patients, speeding up healing and recovery after dental surgeries, reducing pain, this is a safe way with no maintenance that your front desk staff can run for you, so you don't need to waste any of your valuable time. It's just kind of like a side entity for allowing PBM to make a positive impact on your patient's health. And that's the Novathor. But that's it for me. I hope you learned some really great things about PBM and how you can use it in your practice. I really appreciate you taking the time to learn how you can use it to make a positive impact on your patients. Again, I do work for Thor Photomedicine. My name is Sarah Jane. I am a hygienist. I'm a dental and oral mucositis specialist here. I work with all of the oncology centers. I also have my MBA. If you want to talk to me about business aspects, I'm happy to talk to you about that as well. But that is it for me. I'm here for any questions.
Well, that's terrific. Thank you so much, Sarah Jane. You really delivered. I'm just kind of blown away at how many applications, how many conditions that the PBM can be used to address. And I found it interesting, the bell-shaped curve. You know, usually there's a sweet spot, and then if you go beyond that, there's if not a lack of efficacy, there's maybe worse. There's a potential for damage. But it seems like there's two sweet spots. If you just continue the dosage, it moves into the analgesic phase. But in any case, it would be very hard for you'd be hard pressed to do any harm with this device, wouldn't you?
Oh yeah, absolutely. It's really about wavelength and dose. Now, James, who's the CEO and founder, he does a whole big presentation where he really gets into the nerdy physics aspects of dose. But one thing about specifically wavelength, which is why I mentioned stronger is not always better, is that when you have those higher wavelengths, they cause different biological effects, such as, you know, they start to actually vibrate the cells like a microwave. So that's kind of where that pain gets associated, or they get absorbed by water. So that's why 810 is really that sweet spot for taking away pain without getting absorbed by water, where 660 is that sweet spot for absorption within the cells for that healing effect. So yes, you're correct. That bell curve has two sweet spots depending on what you want to do. And that's why we have the dose set specifically for that.
Terrific, excellent. Yeah, I really like the sort of the icing on the cake, which is that you're helping address the opioid epidemic as well. People love
Absolutely.
it. It's so effective that they think it's addictive, but it's not. Maybe psychologically they look forward to it, but that's not a bad thing because they need it.
Yeah, absolutely. I mean, one of the things that I hear from patients, well, practitioners and patients, and the Lancet has actually published on this, is that there is literally no medicine on the market for neck pain and back pain. There isn't. You would think like, oh, you know, opioids or Tylenol or something like that. But for people who have chronic neck pain and back pain, there's no medication on the market for that. And PBM has been shown to be effective for those patients. What dental practitioner do you know who doesn't have neck pain and back pain, right? So
Right.
I've definitely had patients, I've had practitioners who've bought in this unit to treat just themselves and their staff to keep them up and running and you know, don't have to worry about lag time or dealing with the pain. They don't even use it on patients. They use it on themselves.
Well, and to me, that's the ideal situation when you're actually able to use the product yourself. Then you can lead by example and you become a true believer. So I think that's a great point.
Best way to promote it.
Well, now there's lots.
Treat your staff.
There are lots of questions who come in, so let's get to those in the time remaining. Say someone owns a Thor system. What is the first application you recommend that they start with?
What kind of dentist are you? Okay, without even knowing, if we assume that you're a general practitioner, treating both adult and pediatrics, the first thing that I would start with is actually two things. After every single extraction, do PBM because it has a significant effect in healing, and also start a TMJ program because you can find everybody has some type of TMJ issue, and that's something where, like I said, if you use that trigger point, it's pretty immediate, and you will have a positive effect for that patient pretty quickly, and they will notice it like right on the spot. They'll say that they feel like their face is melting because that's literally the pain being alleviated for them. And then you just continue that program for anywhere from 6 to 12 treatments, and they're good. I would say that's one of the biggest things I hear dentists use it, those two things.
Okay. And you had a pretty long list there toward the end of all the different conditions outside of dentistry that PBM is used to treat. Somebody wrote here, was asking, outside dental, is there any treatment for tinnitus?
Yes. Yeah. So obviously this presentation was focused mainly on dentistry, but to give you an idea, PBM is used everywhere. So it is used on tinnitus. I personally have something called thoracic outlet syndrome, which is a compression of my brachial plexus underneath my clavicle, which is why I don't practice clinically anymore. I just teach in the college and then I work for Thor. So for patients, for practitioners who have a lot of things like, you know, tennis elbow, tinnitus, tinnitus is in the ear, trigger finger, those types of things, it is beneficial for all of that.
Wow, so it could treat tennis elbow. You might be hearing from me.
Yeah, I mean,
outside.
To give you an idea, we have like the Olympic running team, they use it. NFL teams, NBA teams, all those big sports teams, they use it. A bunch of famous movie stars use it just to kind of be at their peak performing condition. So it's used for lots of things. We have the VA in Boston who are using it for PTSD, post-traumatic brain injury. They also use it for concussions. I mean, again, it's just that flipping of the switch. That's why it's so beneficial.
You'll probably be hearing from my physical therapist shortly.
Absolutely. Happy.
All right. How do people charge for this treatment, and are there dental reimbursement codes?
Common question. So while it's not standard in dental reimbursement, there are a few codes you can try. In all honesty, it's a bit of legwork for dental practices that I've never really had any dental practice that I work with go through the process to do it. Because a lot of them, like I said, are unspecified codes. In 2019, there was a code that came out for trismus and TMJ. As for how much you get reimbursed, I can't say, because like I said, most of my practices don't do coding. So what they do is they do charge by time. There is a structure in which I will promote about charging by time. You do $10 a minute, usually capping at about $75 to $80. Excuse me, because most of your treatment applications are going to be within 5 minutes, so that's about $50 per application. There are some of them that are a little bit longer, and then that's why I would say do a cap, but I would say cash base is your best model.
Well, I will say that, obviously when a third party is willing to pay for something, it's easier to gain treatment acceptance. But when you're dealing with somebody who's in pain, or has another condition that they really want treated, and you have the confidence in saying, well, this is going to help, it's probably not that difficult to sell, I would imagine.
Oh no, and because like I said, like if you do TMJ, they notice it immediately. So I mean,
right, or that gentleman engineer that was able to drink ice water immediately. That's pretty remarkable.
Yeah, absolutely. And you're making a huge impact because you're actually healing them. So that's very
right.
positive.
How do you clean the system?
Pretty easy. You wipe it down and put a new sleeve on it, especially if it's going intraorally, and you go to the next patient. Our dental tips can be sterilized because obviously if you're doing a dental surgery involving, exposed bone and blood, infection control, you need to sterilize it. But that's pretty much it. Wipe it down, go to the next patient.
And the next question, nice segue, is does the device's sleeve inhibit the light wave?
No, it does not. It's clear plastic sleeve. It does not inhibit the light wave at all.
Great. Can hygienists and dental assistants use the handheld device?
Depends on the state.
Okay.
If it's LED, anybody can use it, but it depends on the state, the actual laser portion.
Okay. That's all right. You don't have to tell us a blow by blow of all the states. What are the reasons, what are the results of the Novathor? Are there studies available yet? Because I know you said it's a new device. And how is the device used in dental practices?
So the Novathor is not a new device. The Lollipop is a new device. That's the intraoral 360 probe. The Novathor has been around for a lot longer. Yes, there are some studies using the Novathor and its benefits. We actually have a ton of testimonials on the Novathor as well. And how is it used in the dental practice? Like I said, it's a way in which dentists can treat all patient ailments without going out of their licensure aspect because it's considered a wellness device. But I have had people who have used it in combination with their dental therapies. So say you do a root canal, you would put the patient in the Novathor the day before the root canal, the day of the root canal, and the day after, and it basically hits all of your lymphatics and helps accelerate that healing and reduction of pain for, optimal healing for that patient. So that's kind of how you can incorporate it in. Same thing as if you have really anxious patients, have them go in the Novathor before you put them in your dental chair, and it will relax them for you. So that's helpful too. So that's how you can kind of use it.
Very good. And if people want more information, they can just contact you at the information on the screen. And with that, let me just share with everybody that in a few days you will receive instructions for applying to receive your continuing education, and that will indeed include a recording of today's webcast. I received a number of questions about that. And now I'd like to invite you to mark your calendars for Thursday, September 22nd, when our special guest presenter will be Adele Reishi, whose presentation is titled, Get Active. Are your patients inactive or just plain reluctant? Everyone talks about and understands active and inactive patients. What remains largely misunderstood is the reluctant patient. This presentation will challenge you to perform outside of the box work and redefine your patient classifications. Adele will first explore what characterizes the active patient and the strengths they bring to your practice. Next, we'll delve into how to identify and define your inactive patients. With this as backdrop, we'll learn what characterizes the reluctant patient, how to inspire and promote them to a high level of value for the practice and themselves. It all happens on Thursday, September 22nd. So be sure to mark your calendar, save the date, and watch your inbox for registration information. Until then, this is Danny Bobrow thanking you for your commitment to practice perfection. And once again, thank you, Sarah Jane.
Thank you. All right. Have a
Goodbye,
good evening.
everybody.